having some meetings, but the union is really calmed down. Well, I can be there, but I don't think.
Okay.
And most people, fortunately, are here. Like Derek is just coming in next week.
Yeah, Derek and Mike
But most important people like you are here too.
No, we hang around and my wife is coming tomorrow.
Oh, nice.
And Paris is her dream city.
Oh yeah.
From day one, I met her. She was talking about Paris. And we have 5 children. She's coming out of Paris.
It's the first time.
Yes.
Oh, nice.
Yeah, she has been to the Netherlands and the Germany.
When she comes in?
Tomorrow.
Tomorrow.
Yes, yeah.
Tomorrow is Friday. Yes.
Good afternoon. Can I invite everybody to take a seat? Maybe some more people will come in, but that's okay. Welcome to the afternoon parallel session on advancing the development and implementation of TB diagnostics. My name is Marieke van der Werf and I work at the European Centre for Disease Prevention and Control in Stockholm. And I'm co-chairing this session with Deborah Bate, and she's from EDCTP too. We have 6 presentations for you this afternoon, and we plan to run it by having a presentations, then having a number of questions. And if there's time at the end of all 6 presentations, then we will have a general discussion. We also have people online. Most welcome to you, and nice that you participate. You can post your questions in the chat, and we will try to keep an eye on it and ask the questions to the speakers if relevant. So, Deborah, you are going to introduce the first speaker.
Yes. So, good afternoon, everyone. Our first speaker is from one of the EDCTP 2 funded projects, Erase TB. It's Claire Calderwood, and she's affiliated to LSHGM and BRTI. And she will talk about the implementation of integrated health checks for TB-affected households in Zimbabwe. The floor is yours.
Thank you very much.
Is it?
Okay, cool. Thank you very much for the opportunity to talk about our work implementing and evaluating integrated health checks for TB-affected households in Zimbabwe. My slight apology is that I only think I mentioned TB diagnostics once in this presentation, but hopefully it will give you food for thought about how we implement studies looking at TB diagnostics and TB household contact tracing. So I thought I'd start by reminding us all that TB remains a major public health threat, and continuing with the status quo is going to be insufficient in order to meet global TB targets. In addition, the ongoing TB epidemic, alongside those of HIV and undernutrition and other conditions, are occurring alongside an expanding epidemic of non-communicable diseases, which, along with the overall goal of universal health coverage, demands a move away from siloed disease-specific models of care. And we know very well that both TB and other epidemics are reinforced by structural factors, and the poorest experience but the greatest burden of poor health, both at a global level and the poorest in any community, and they experience the highest barriers to accessing healthcare whilst being least able to afford the devastating consequences of poor health. So we also know that TB exists as part of syndemics, and TB multimorbidity is very common, and this just illustrates some of the conditions which we know are associated with TB. As a result of shared social, structural, and biological factors, we propose that TB household contacts, and this has been shown in several studies with various conditions, are also at increased risk of these conditions. So therefore, TB is a syndemic that doesn't just affect the individual in isolation, but affects them as part of their family and as part of their community. So just to introduce integrated health services. So integrated health services address more than one health condition. They promise to be more person-centered, being able to address the problems that someone is presenting with, rather than focusing just on a single disease that's of interest to a program. They are promised perhaps to be more efficient, delivering economy of scope through sharing of resources, and promote progress towards universal health coverage as a goal. One way in which we might advance progress towards universal health coverage and we might integrate services is by leveraging on traditionally strong vertical programs. And this has been studied extensively in the context of HIV and with increasing interest in this within TB programs. So we hypothesized for this study that leveraging TB household contact tracing as an intervention to deliver integrated health services might be a way to improve the health of people with TB and those they live with, both reducing their risk of getting TB, improving TB outcomes for people who do develop incident TB as household contacts, and improving overall well-being. So as the chair kindly mentioned at the beginning, this was a nested sub-study within the EDCTP-funded Erase TB study. At the Zimbabwe site, Erase TB is across 3 countries in total. And it forms my PhD study, which is also funded by the Wellcome Trust. So the overall aim of the study was to integrate the feasibility and potential impact of integrated multi-disease screening through a pilot screening package for members of TB-affected households in Zimbabwe. In line with the recruitment criteria for the parent study, we recruited household contacts aged at least 10 years who were attending an Erase TB visit at baseline or up to 12 months from the TB diagnosis in the household. And that really was just because of the timing that we needed to complete the study within. People who had TB in the same households, in according with the recruitment criteria for the parent study, they had to be at least aged 18 years. At or within 12 months of the end of their TB treatment, were invited to come back to the study. Recruitment to the study took place between April 2022 and April 2023. So these are the conditions we included as part of our health check. And this was really developed based on previous studies that we have done as part of the Through Zim group in Zimbabwe, looking at integrated screening for young people, for people, adolescents as part of school-based interventions, and for healthcare workers. And with very strong input from our TB Community Advisory Board, who input onto what were the conditions that they considered to be important within their communities. So we included conditions that were deemed to be important public health problems in Southern Africa, either based on epidemiological data, so high prevalence, or based on the input from our Community Advisory Board, with a particular priority on conditions which are known to increase the risk of someone developing TB. We required there to be a validated point-of-care test available in order for us to be able to deliver screening on a single day. And we needed there to be facilities for diagnosis, treatment and care to be available within the local community from existing services in order for us to be able to refer people onwards. We offered on-site information, education and counselling for everybody who participated in the study, as well as on-site testing with Expert Ultra for people who had symptoms suggestive of TB. And we gave out reading glasses, and then on the right you can see all the referral pathways, which either used primary health clinics, secondary level government services, or were through local NGOs. The outcomes we were interested in the study were uptake of screening, the number of people who were screened, the yield, the number of new diagnoses that we made through the study, and how many people were able to link to care, which we defined as attending at least one appointment for the study. Just to mention, there is a 12-month follow-up for this cohort where we will be able to look at whether people actually managed to start on treatment and retain in care at 12 months. So this is the recruitment of the participants in the study. So we recruited 480 people who attended a raised TB. Sorry, there were 480 eligible people who attended an erased TB visit, of which only 11 elected not to participate in the integrated health screening, which is so 98% participated. From the same households, we invited 272 people with TB to come back. This was slightly more onerous on the individuals because they weren't already coming for a study visit. And out of those, only 90 attended and participated in the screening. The most common reason for people not attending was that they had moved away from the local area, and unfortunately 7% had passed away since their TB diagnosis. So to summarise the demographics of our participants, around a quarter of the household contacts in this study were adolescents. The majority of the people with TB were men, which was in contrast to the household contacts. Overall, the gender balance was fairly sort of even across the households once you added the person with TB back in within their household. Looking at employment, most of the adolescents were in school, and employment was looked at in anybody who was not in school or in college. Only half of people, on average, were employed, and informal employment was particularly common amongst people who had TB. Looking at some of sort of the behavioural or life circumstances as risk factors for developing TB, 18% of people with TB in our study in Zimbabwe had a history of mining activity. To give you some context to that, the study was conducted in Harare, the capital city, where there's not a lot of local mining that goes on, but people commute out of the city to engage in mining activities, a lot of which is artisanal and small-scale mining. Around a third of our participants reported living with severe food insecurity, as measured using the FAO Food Insecurity Experience Scale. Smoking was relatively uncommon, whilst a similar proportion of household contacts and people with TB reported drinking alcohol. Alcohol dependence was much more common amongst people who had TB compared to their household contacts. I included COVID vaccination in this slide because we asked about it, given the timing of when we conducted the study, but really to highlight that less than half of this population had received a COVID vaccine. We know from other data that our group have conducted in Zimbabwe over the same time period that national coverage of COVID vaccinations was around 70%. So there's a really big gap in access to COVID vaccination as a free intervention amongst this group of people compared to the population as a whole. So this slide summarises the yield of screening for stratified by household contacts and people with TB. Just to orientate you to the plot, on the right in grey is a small number of people who declined to participate in screening. In dark blue along the left-hand side for each plot are the people who screened positive, and in green are the people who reported they already knew they had the condition. So the combination of the dark blue and the green bars is the overall prevalence of disease. So the overall prevalence of HIV amongst I have to look at this, I'm afraid, sorry, because I can't remember all the numbers. The overall prevalence of HIV amongst our household contacts was around 18%, and amongst people with TB was around 35%. Looking at people with TB, considering the fact particularly this is the end of their TB treatment or after their TB treatment, around a quarter of them were underweight, around 10% had an elevated HbA1c, and 45% had mental health symptoms, of which the vast majority had not been detected during the time that they had been on TB treatment. Looking at our household contacts, the overall prevalence of TB, so co-prevalent TB, was 1%, and 6% of people had a history of previous TB. Around 6% of people were underweight and about 10% of people had an elevated HbA1c, both of which are conditions that were unrecognised but could be increasing their risk of developing TB. And again, 30% of people reported mental health symptoms within this cohort. So to move on to looking at linkage to care, obviously screening alone is going to be insufficient in order to be able to improve outcomes or prevent people from progressing to developing TB in this setting. Whilst everybody who we diagnosed with HIV as part of this study successfully linked to care, linkage to care for other conditions was much lower. And there's a suggestion, although the numbers are small, that linkage to care was lower amongst the TB index cases compared to their household contacts. And the other thing that I think is important to highlight in this is that around half of people linked to care for mental health symptoms or vision impairment. I'm happy to give you more details about what this involved if you want at the end. But those were both delivered through NGO-led services, whilst diabetes and hypertension services were through government clinics, and linkage to care for those services were much lower. So in summary, we showed that there's a very high uptake of integrated health checks amongst TB household contacts. It was lower amongst people with TB, which perhaps is more representative of people coming and participating in the study, as they weren't already coming for a study visit. And I think it was important to highlight that actually this is a very mobile population in our context, with a lot of people having moved out of the local area since their TB diagnosis by the time we wanted to invite them back. We found a very high burden of unmet healthcare needs, both amongst people with TB at completion of their treatment and amongst TB household contacts, and a lot of these had been previously unrecognised. And this includes risk factors for TB and poor TB outcomes, such as diabetes, undernutrition, and mental health disorders. Linkage to care was suboptimal and was variable across conditions, and I'm very happy to talk about that a bit more and what we think the reasons for that might be. Limitations of this study are that we conducted all the screening on a single day, and as we know, that's particularly an issue for hypertension, where there can be misclassification of hypertension status based on screening on a single day. We use point-of-care tests. We know that HbA1c offers suboptimal sensitivity for diagnosis of diabetes, particularly in African populations, and there are no sort of very widely validated point-of-care tests, but that's something that we're working on. So I wanted to end by proposing a radical reimagining of TB screening. There's obviously lots of issues that why this might not work, but perhaps we could rethink of TB screening rather than just being a vertical intervention where we only go in and look at TB, which is only prevalent amongst 1% or in systematic reviews 3% of the TB household contacts, but this being an opportunity to offer integrated screening for a variety of conditions, and that would be tailored towards a local context, but I've suggested what might be relevant in our setting, with linkage to TB preventative therapy. It would be important to promote health education and strengthen health education programs, focus both on TB and other conditions as part of this, and ensure that people are linked to nutritional support and social protection. I'd particularly like to thank some of my colleagues from ThruZim and the NTP who've helped me in putting this together. I'll end by giving my acknowledgements, particularly to EDCTP for funding the Erase TB study, without which this would not have been possible, and the Wellcome Trust who funded my individual PhD fellowship, as well as all of our partners that are shown there, and my colleagues. Thank you.
Yeah, thank you, Claire, for a very interesting talk. We have time for 1 or 2 questions before we move on. Are there any questions here in the room?
Frank Koblenz, University of Amsterdam. Thanks very much for the presentation. I had a question about your study aim says it's about feasibility. But did you do any qualitative work to find out how feasible it actually is with health services, with clients and so on? Or are you planning to do that?
Yes, but I'm still doing my PhD, so I haven't finished it yet.
Okay, because it will probably shed light on all these questions around
Yes.
linkage to care, because I can imagine. So on the one hand, this is an intervention that apparently to some extent works, but it's on a very small subset of the entire population that you would say would be eligible for these kind of screenings. And then it all comes down, I think, to whether you can actually provide linkage to care, because if you can't, all you do is raise demand without actually addressing the demand. So that would be my concern.
No, I completely agree with you. And that's something that obviously there's been a lot of studies that looked at screening in lots of contexts. And unless you can get people onto treatment, it's kind of pointless. So we are doing qualitative work with the providers from sort of who provided this study, as well as healthcare providers in the local setting and our participants. And the big barriers sort of that come out really strongly are around access fees. So it costs depending on clinics, primary care usually about $5 to access primary care and $10 for a secondary care appointment in Zimbabwe, which is completely unaffordable for people. I don't think I presented it in this, but 90% of the participants in this study were living on less than $1.90 a day. So yeah, it's a huge problem that needs to be addressed if we were to take this further.
We have one more question over here, and then I think we move on to the next speaker and save questions to the end. Yes.
Yeah, thank you very much for the presentation. So I was just thinking in my mind how this will work in some of the low middle income countries where you require a number of experts or specialists to look at these integrated conditions. Our setup is such a way that if you all the conditions you mention should come with special people who must assess. How do you, I don't know, but how do you think this will play out if you have to get this implemented in countries that are not used to this kind of system?
Yeah, I could talk for ages about all of the sort of things we thought about around what would actually be taken in order to implement this at scale. However, I think my short answer is that the same thing was said about HIV care, and as a lot of people have said, we need to learn from the lessons that we've seen in HIV and how we've managed to decentralize and scale up care for HIV sort of hugely and try and use a similar model to offer care for other conditions, particularly for NCDs, which are going to become a huge problem in Africa in the coming decade.
Thank you. Our next speaker is Alex Scott. He's from the Center for Lung Infection and Immunity of the University of Cape Town Lung Institute in South Africa. And he will talk to us about evaluating the impact of computer-assisted X-ray diagnosis and other triage tools to optimize expert-oriented, community-based active case finding for TB and COVID. The floor is yours.
Thank you very much. Thank you very much for that kind introduction. My name is Alex Scott, as was mentioned, and I'm going to be presenting on this very important topic that is both innovative and topical at the moment with regards to AI in healthcare. We have this diagram here, but as we, if those of you that don't know, the 2023 TB Global Report just came out. I think it was a day or two ago. And of the 10.3 million people in 2022, 3.1 million were undiagnosed or unreported. So even though there was an increase in the reportings, there's still a staggering 1 in 3 that are not diagnosed or reported globally. And if we do not take these diagnostic tests out of the clinic and into the community, we might be missing these so-called missing millions, as well as those who are probably infectious in the community and driving transmission. I want to take you on a little bit of a journey because detecting cases in the community has been restricted by a lack of sensitive and user-friendly point-of-care diagnostic tools. And to address this, our unit planned a program of activities or sequential interlinked studies with an overarching aim of optimizing a model for expert-orientated active case finding for TB, which is known as the EXACT model. So initially, through the EDCTP funded EXACT-1 study, this was a proof of concept study that was done in South Africa and Zimbabwe, where we put point-of-care diagnostic tools into a truck with a generator, and we found that there was a 9% TB detection rate in those that were symptomatic and had HIV, and this was published in Lancet Infectious Diseases in 2017. We then moved to try and demonstrate the efficacy of this scalable model using the older generation Expert Edge, housed now in a panel van, almost a mobile clinic where we screened just over 5,000 people in South Africa. And once again, we found about a 10% detection rate in symptomatic and HIV-positive individuals. And importantly, Expert detected almost all the probably infectious TB, where I know it's difficult to reference what infectiousness is in TB. But what we did in this study was measure it as a composite reference standard to either smear positivity, cavitary disease detected on X-ray, as well as cough aerosol sampling positivity. This was recently published in Nature Medicine this year. One of our ongoing studies, another EDCTP funded study, is the EXACT3 study, where we're now validating this model, validating its feasibility and its impact. This will be a much larger scale study in 4 sub-Saharan, or that's currently ongoing, that is being conducted in 4 Southern African countries, in South Africa, Zimbabwe, Zambia, and Mozambique. And we hope to shed light on the results very soon. We know that chest X-rays have been used for screening for TB for decades, and there's been a technological advancement of chest radiography from analog to computed and more recently to digital X-rays. However, there are some drawbacks. We know that it requires expertise, there's infrastructure requirements, and there's inter and intra-reader variability. We've gone a step further now with ultra-portable X-ray systems and what is known as computer-aided detection. Computer-aided detection, or CAD, is an AI-driven system which is based on deep neural learning networks that interpret abnormalities on a chest X-ray, which are suggestive of TB. The results are usually expressed as an abnormality score, either 0 to 1 or 0 to 100, and are deemed positive or negative if the abnormality score is above or below a pre-calibrated threshold. There's also a heat map as shown in the image that highlights abnormalities. There's certain CAD software that only give you an abnormality score and a binary yes/no for TB, but some other software provide further insight into specific abnormalities on the chest X-ray, such as consolidation, cavities, or effusions. But there's still many unanswered questions. And what is the adjunctive role of this novel, very interesting tool, and how can it fit into the EXACT model? Is it feasible? Is it cost-effective? And so we aimed to answer those questions in the EXACT19 clinical trial. This is a large-scale trial. I know it's a very busy slide. I just wanted to show and illustrate the complexity of this trial. And it's another EDCTP-funded trial that incorporates 3 major components. The first one is an RCT, which I will go through shortly, which is determining the utility of CAD as a triage tool to optimize this EXACT model that I spoke about. We're also then looking at a more observational aspect where we're determining the value and impact of CAD in healthy individuals. These are individuals that are in the community with no comorbidities and are asymptomatic. And then thirdly, as the name says in 19, this was started when the COVID-19 pandemic started in 2020. And we initially wanted to look at the feasibility of co-screening for TB and COVID-19. Obviously, as the COVID-19 pandemic evolved, we had to evolve with it. And we're now looking at COVID-19 in those that are immunocompromised, such as HIV infected individuals in the community. But today I want to focus on the RCT, which is an important aspect of this trial and an important question that needs answering with regards to whether CAD can fit into this EXACT model. So we wanted to look at screening individuals who are at high risk, and by high risk we had those that were symptomatic, those living with HIV, those with a history of previous TB, diabetics, and contact persons. We were planning to enroll approximately 6,000 individuals, and they will be randomized into either CAD plus expert or expert only. And what I mean by that is an X-ray will be done. It will run through the CAD analysis. If the CAD is above the pre-calibrated threshold, they will then qualify for an expert test as a diagnostic tool, compared to whether we just expert everybody. And we want to see whether CAD has an important aspect to minimize the excessive expert testing of trying to do an expert test on everybody, instead of using a tool to try and sieve out those that are less likely to have TB in the community. We chose a primary outcome measure of time-specific TB detection rate, and this is due to, although chest X-rays being very sensitive, it is unfortunately suffers from specificity issues. And this is why we have to add a diagnostic tool such as Expert, where it will improve the diagnostic strategy. Just important to note that everything that I've said now is point of care. everything is housed in one van, taken into the community, which is run by 2 to 3 healthcare workers. This is important. Everything is battery operated. We do not have internet. Everything is done offline. And we want to see if this model works. We want to get to the most vulnerable populations and where we think transmission and probably infectious individuals are residing before they get to the community. Just to show you a little bit of our setup of how we work, on the left-hand side, this is our setup in Zambia, and on the right, just a show of the ultra-portable X-ray system that is used in South Africa. And you can see we set up all our technologies, our laptops and everything, where the CAD analysis is run offline in the rural, community-based peri-urban settings. So very early results. Of course, many projects suffered from delays in initiating because of the COVID-19 pandemic, but I'm just going to give you very brief results from early on. Important to note at this point, the Zimbabwean site were not active, and so I present results just from the other 2 recruiting sites. So you can see we enrolled about 505 so far, and of that, around 26% or 27% were HIV infected. Of the 505, we had 33 already that were TB positive, and in our reference standard, TB positivity is either expert ultra and or sputum culture positive. And you can see that there is the breakdown between the 2 countries with quite a larger amount of TB in the South African site, which may be indicative of the populations and the setting. And when we broke it down into those that were symptomatic or those that were subclinical or asymptomatic, importantly to remember that our inclusion criteria are high risk. It doesn't necessarily mean only symptomatic. So someone could just be a contact person, someone could just have diabetes. We deem those high risk individuals in the community. And about 40% were asymptomatic in the community and had microbiologically confirmed TB. So another important aspect is to look at whether we can detect the infectious patients. Again, I mentioned earlier that it's difficult to reference what infectiousness is in TB. But when we look at the 3 components that I spoke of earlier, we found that almost 20% were smear positive, probably illustrating a potential for infectiousness. But what about other markers? And the most important one that we would look at would be radiological. And we are looking at cavitary disease on the chest X-ray. And so to illustrate this, I just wanted to provide 2 very short case studies on what or how the Exact-19 trial can have an impact in the community. Just to note that at the South African site, we also perform PET-CTs as part of this trial. Of course, this is more of an academic aspect of the trial and not fitting in the exact model. But it will be a very interesting aspect to look at the discriminatory nature of chest X-rays read by human readers taken in the field, as well as CAD, and comparing that to a radiological reference standard of PET-CT. So this is a 37-year-old male, asymptomatic, does have a previous history of TB and is HIV negative. The point of care expert was negative and his smear was negative. And you can see this is his chest X-ray here. And according to the human reader, this was reported as normal. It underwent CAD analysis, and it had a score of 21.7, and you can see on the heat map that there are no major abnormalities that the CAD raised. This sputum culture came back positive, and when we did the PET-CT on this individual, there were small thin-walled cavities in the right lower lobe. I'll try a second case, where there's a 35-year-old female, asymptomatic, no history of TB, HIV negative, a relatively healthy individual. Her expert came back positive, point of care as very low, smear was negative. We can see her X-ray here. This time it was shown to be abnormal, with the human reader saying a probable active TB with a potential cavity present. You can see the CAD now lit up with a much higher CAD abnormality score. The culture came back positive, and once again, when we did the PET-CT, multiple apical cavitating nodules bilaterally and a thick-walled cavity in the left lower lobe. So this is important as these individuals were diagnosed in the community. These individuals were asymptomatic. These individuals perceived themselves to be relatively healthy. These individuals would not have attended the clinic and would probably have been in the community, potentially contributing to community-based transmission, if not for an active case finding model. So to conclude, the exact model may be a key strategy to interrupt community-based TB transmission. We detected in our very early results a high burden of TB using ultra-portable X-rays, CAD, and other offline tools in the community. There was a significant minority that we thought were probably infectious, and a large proportion being subclinical. And do these individuals contribute to community transmission? It's difficult to say at this point, but within the trial, we're also looking at other proxies for infectiousness. We're looking at household contact tracing. We're doing cough aerosol sampling. And we will also look at QFT conversion in the household contacts. Finally, these data do inform active case finding strategies in high TB burden settings. Of course, this is not an isolated work. There are many, many moving parts and many individuals that contribute to such a large trial. Along with myself as the South African site PI, I would like to thank Professor Helen Ailes, Dr. Junior Matsvangwa, and our global PI, Prof. Keaton Dada. Also our research teams, our partners and collaborators, the participants, and of course EDCTP for funding the trial and making all this worthwhile. Thank you very much.
Thank you, Alex. We have a few minutes for questions. So who can I give the floor? I see a hand over there.
Yeah, thanks for the presentation. So I know that the CAD version 7, it appears is well calibrated for adults, but the question of having children TB is becoming a big issue. Have you stratified your data by age to give some information on this?
That's an excellent point. We haven't. In our trial, we're only looking at adults. The specific CAD for TB, which is from Delft, is not approved for children as yet, but there are some CAD software that have gotten certification to use in children. Importantly, none have, to my knowledge, have been conducted in a pragmatic approach, in a very clinical approach without any biases. So that is definitely an aspect that should be considered, but in our trial, we're only focusing on adults in the community.
Adam Pennicholson from FIND. Thanks very much, Alex. A great presentation. I was wondering, in your community, did you have a high proportion of participants who were sputum non-productive? And did you happen to look at CAD in those individuals at all?
Yes, absolutely. So another important aspect is, especially in the subclinical or the asymptomatic individuals, how do you get a proper sample? And if that sample comes back negative, are you sure that it's negative because of the actual TB negative, or is it because they didn't give you a proper sample? In our EXACT2 study, we showed that expert in the community is only positive in 50% of culture-positive individuals. So there is a problem, and how do we go about this? We do sputum induction on site for those that are unable to produce a good quality sputum sample. We're also actually investigating this and actually trying to quantify or objectively look at the specimen quality, doing something like a Bartlett score, something for a small proportion, just to see what kind of objective quality the sputum is. And then the other aspect is to look at what other technologies can we use. There are other urine-based technologies, there's other new things coming about like saliva testing or tongue swab testing or something like that. But I do agree, it's not the easiest, and it is something that we need to keep in mind when we are looking at these individuals in the community.
Sorry, Katharina Kranze from Zimbabwe. I was wondering, because I just didn't quite get that on the slide. So it's community-based active case finding. How do you make sure that the people you want to see, which are diabetics, people living with HIV, contacts, come forward? Or is it house-to-house testing, or how do you identify them? And then my other question, which relates to the two cases, which are obviously quite interesting, both of them were asymptomatic HIV negatives, not diabetics. So what were they contacts? And that's the reason what triggered them to come. And it seems then they were both from South Africa, because you had CT scans.
Correct. Yeah.
So these kind of subclinicals, obviously South Africa 9%, Zambia
2%.
2%, yeah. And probably Zimbabwe also more in the range of 1 or 2%.
Yes.
vastly different. And in South Africa, if the question is expert positive, TB culture may be positive or not, is it really then TB, or is it leftover TB, considering the unbelievably high TB rates you have in Cape Town?
Sure.
Thank you.
Sure. So for the first question, one thing that is very important in all of these kind of active case finding studies is involvement of the community. And we focus very much on collaborating with the community advisory boards. We have community leaders in each of the communities that we go to, who obviously know those communities much better. They know the community individuals, those that comes to churches, to shops, these surrounding schools and so forth. So we know the parents of all of those individuals in the community. When we go out to certain areas, we look at what we call TB hotspots, which have been identified throughout our last decade of exact case finding. And we work with the community advisory boards to try and get the individuals to us. What's important here is that I didn't focus on it, but we are having an observational component as well. So whoever doesn't fit our criteria as high risk will still go into the trial as a healthy individual. So we do recruit the majority of those that we screen, but specifically for the RCT, we focus and utilize the community advisory boards, which have been amazing and an absolute godsend when we do community-based studies like this. And then to the second point, I agree with you. Unfortunately, purely by funding and issues on logistics, we can't do PET-CTs in all sites. Definitely the proportions or the prevalences of TB is much higher in the South African context, and we know that. What's important to note that both of those cases were culture positive. And though it is our reference standard, it might not be the perfect reference standard, it is the reference standard, and so we would classify them as TB positive, microbiologically confirmed TB positive. And we are using culture across the board in all sites, which is quite an endeavor. But it's important for us to answer the question that we're looking at.
Okay. I would like to go to the next presenter to give everybody some time to present and have questions, and I hand over to you.
Thank you.
Yeah, thank you, Alex. So our next speaker is Akash Malhotra from Johns Hopkins University, and he will talk about the health system costs of decentralized TB diagnostics testing with mobile TrueNAT MTB-RIF versus hub and spoke twin expert MTB-RIF in Mozambique and Tanzania.
All right. Thank you for the introduction. Hi, everyone. Thank you for your time. Thank you for being here. My name is Akash Malhotra. I'm from Johns Hopkins University and the University of Washington in the US. And today I'll be talking about health system cost of decentralized TB diagnostics with mobile TrueNAT MTB-RIF versus the hub and spoke gene expert in Mozambique and Tanzania. And today I represent the TB CAP consortium before I present. I have no conflict of interest to report. A note for our funder, this presentation was funded by TB CAP. It was produced by TB CAP, which is part of the EDCTP2 program supported by the European Union. The views and opinions of authors expressed herein do not necessarily state or reflect those of the EDCTP. Before I dive into talking about costs, I'll want to, of course, give some context of our implementation strategy. So in our standard of care, imagine a typical setting in a primary health area where our clients are seeking care. They come with some symptoms, they show up with some symptoms. They are tested for TB, so some samples are collected. And then those samples are collected at these primary health clinics, and then they are sent to a more centralized hospital or a laboratory for testing. So a sample transportation mechanism is in place. It takes a few days for the test results to be finalized. The test results are sent back. And then the client is expected to be at the clinic a few days later to know their results. So it takes a decent amount of time, and then there are, of course, costs involved, because in a typical scenario, if the client is coming back twice, they are paying a lot of out-of-pocket costs twice. There's some sample transport, as we see as well. And a lot of times there's also microscopy done at these primary health clinics, but it's also done in combination with a confirmatory expert. In our intervention, which is the decentralized testing, what we hope we've done already is the client is coming to the clinic. There is the TrueNat mobile test performed at this primary health clinic as well, so there's no third layer, there's no higher health facility or a lab. And then the samples are collected and analyzed at this health center or clinic, and the results are given back on the same day itself. So the client can be initiated on treatment, ideally, in an ideal case scenario, on the day they get tested. Keeping that context in mind and then building up more context on our cost and cost effectiveness. So we've, for the broader study, for the whole study, we aim to do a costing and a cost effectiveness exercise from a modified societal perspective. So we look at health system costs as well as the costs borne by the patient. Then when we look at our costing endpoint, we're looking at cost per test. We're looking at cost per TB treatment initiation within 7 days of the TB test. Just wanting to point this out now because this would be important for broader context, that the cost per test, in that the denominator is everyone who got tested. But when we talk about cost per TB treatment initiation, we are only talking about the outcome, those who were a confirmed TB, microbiologically confirmed TB case and initiated treatment within the first 7 days. And then our cost effectiveness endpoint will be the incremental cost per additional patient linked to TB treatment within 7 days of the test. Our analysis for the cost effectiveness endpoint is still ongoing. And so the focus of this presentation would be what's highlighted in red. We'll focus only on the health system cost today, and we'll only be looking at the cost per test across both our arms. So diving deeper into the health system costing approach, we've used a combination of both micro and macro costing to estimate per test cost by the health system. So this involved conducting facility assessment. So we conducted interviews of costing coordinators across all our 4 sites. And these coordinators were managing a total of 29 clinics in Tanzania and Mozambique. We developed some implementation costing tools, and we'll have a look at them in the next slide. But just to say that these were developed in consultation with the coordinators and the study team from all these 4 sites, because we want to get an understanding from them as to what they feel really goes behind getting one test done. So these were actually developed in a more bottom-up manner, if I may say. We also looked at trial expense reports to just see where all expenditure was done and to sort of get more strengthened cost inputs, if I may say. And then, of course, product catalogs to triangulate prices of the testing equipment and consumables were also referred to as well, because at most times it is challenging to get exact cost. And then the more information we have, the more confident we are with our numbers when putting into our model. Talking about the costing tools, so we had 3 sets of tools mainly. The first one in the lighter blue are tools we developed for the external laboratories. These are the centralized labs which are in the standard of care, analyzing most of our tests. Then we developed tools for our intervention and our control clinics. And then we developed tools for the sites itself, which look at more, of the admin cost. So talking more specifically about the first 2 tools tools over here, we wanted to get a sense of the TB diagnostics infrastructure. So this would be around what machines you have, how many tests are you able to do in a day, are some of these machines not working, who are the staff involved, how much time they spend. So just getting an idea of that and validating these answers with our site coordinators. How sample transportation is done, what are the different costs of your consumables, utilities, maintenance, from a truly implementation perspective, what really goes behind running a final test in both our arms. And then, of course, staffing and training costs, communication, monitoring, and evaluation. So we got most of our information from these tools. But at the same time, we also wanted to collect tools from the headquarters, like the main site offices, because what might happen is sometimes clinics might not report certain costs because they were centrally paid for. So it helps us fill in any missing gaps, but also get other costs which are used to run the clinics in both arms, which are only borne at a more central perspective. So It could be around site finalization. Maybe they're doing one big central training for all the clinics under them. Again, any equipment and consumables used at the central site, and then other admin and office cost. We got an idea from there. We then categorized the per test cost for both Tanzania and Mozambique across both arms into 8 categories, namely the cost of the testing cartridge, the other consumables involved, and other consumables here would include reagents for the test, or even other consumables such as face masks or gloves, which are worn by staff which are conducting or analyzing our test. Then the cost of the equipment itself, and by equipment apart from the expert and the mobile machines, we're also referring to storage equipment like refrigerators or other equipment that were procured for the study. Warranty and maintenance of the equipment, training costs, communication and M&E, staffing, and then all other costs as miscellaneous. So miscellaneous could even include costs for the IRB itself, spreading it over a larger time period. Then for all these 8 cost categories, we estimated the ranges and then model cost outputs with 95% credible intervals via Monte Carlo simulation to estimate our per test costs. Starting with the overall results and then diving into the 8 categories in the next slide. So the estimated cost per participant using on-site mobile TrueNAT was $53 in Mozambique and $42 in Tanzania. For the standard of care or the hub and spoke arm, the cost per participant was $40 in Mozambique and $21 in Tanzania. So first I'll spend my time going through at least the major categories, the major drivers. So in Tanzania, as I said, the intervention arm, it was $42, the standard of care was $21. What might seem surprising is if you look at the equipment cost, why are we seeing such a high cost for the equipment? The TrueNAT Mobile isn't a really expensive machine compared to the expert, but that's mainly because of how the study is set up in the first place. We are using a TrueNAT machine per clinic, per primary health center. So even the smallest of clinics would have its own testing machine, whereas the expert device would be shared by multiple clinics, maybe 6 to 8 or 10, depending on the context of setting. Clinics are sending their samples to be tested by one machine. So there's better utilization in terms of percent utilization. So of course you're saving costs because you're sharing an equipment. And applying the same logic, warranty and maintenance as well, because it's linked to an equipment, it'll be much higher. When we look at staffing costs, because there are more staff involved, each clinic will have some staff who are collecting the samples, analyzing the tests. So cumulatively, because there are more staff involved, so staffing costs will also be higher. Cartridge cost, as we see, it's slightly lower for the TrueNAT arm. And then other costs are fairly equal. If you look at training, if you look at the miscellaneous costs, the communication, and the consumable costs are slightly higher in the intervention arm. Before I move on to the next slide, also noting that there will be a lot of heterogeneity between the two countries because inputs are different, the way things are done are different, the cost of items are itself different. The same item might cost different in different countries, but we're at least, we'll see later, we're at least getting the same trend. So when we talk about Mozambique, the total cost in the intervention arm is $53 cost per test. And then in the standard of care, it's $40. And here again, if we look at staff, similar trends from the previous slide, the staffing cost is higher, the equipment cost is higher, the cartridge cost is slightly lesser in the intervention arm. But here we see the cost for other consumables is very high, and we found it a bit challenging to really see why it was so different when we compared it to Tanzania. But as I said, it's a different setting altogether. Maybe it was also still COVID in a way, so maybe a lot of PPE was being used, or a lot of inputs for a lot of microscopy might be done, as a result of which the cost for consumables, other consumables, was slightly higher when we're just looking at Mozambique. And then again, warranty and maintenance, we see similar trends, and then costs fairly equal, like we saw in Tanzania as well when we talk about communication, M&E, training, and other costs. So our key takeaways are that the per test cost of decentralized molecular testing for TB was more expensive than a hub and spoke approach. But here, again, a big disclaimer, this is just the per test cost. this is only from a health system perspective. This is not the total cost, which includes the patient perspective as well. And this is, and in the denominator, we are not looking at number of TB cases found within a week, which is the primary outcome of the TB gap core study. When we'll be done with the final analysis in a few weeks, if we are seeing that there are many more cases found in the intervention arm, then you might see a favorable outcome wherein the per test cost, the per outcome found per patient diagnosed cost is lesser in the intervention arm compared to the standard of care. So we'll release those results soon, and we'll make sure to disseminate. And the primary drivers again being equipment, staffing, and warranty costs, and then consumables were heterogeneous, varied by country, and we are currently completing a full cost effectiveness analysis, and we'll share results soon. And to know more about this trial, we also are presenting at a symposium later today in room 341, where we'll talk about the experiences from this trial in both Tanzania and Mozambique. So we might also get some answers there. I don't want to spoil anything for a symposium later today. Yes, I'll end with the acknowledgements, thanking all the sites, CISM, INS, IHI, NIMRI, all the staff who've been really helpful, especially with the data. It's things like these are challenging to collect, and especially in a multi-country study, we received good cooperation. Then all the organizations involved, a special thank you to them. And most importantly, to all the participants, their families, and everyone else who made this trial possible. Thank you so much.
Thank you very much. We have time for 2 questions, I would say. And I see Salome here in the front.
Hi, Salome Charalamas from the Aurum Institute. Akash, I'm just wondering if you guys have thought of modeling the results. So it's nice that we have results from 2 countries, but you might find, that you might find very different cost effectiveness if you're going to other countries, maybe where people's time might be more expensive. And that kind of thing. So, just to encourage you to model this to other countries as well, like once you've finished the study.
Yes, I think that's a really good point. And when we'll be doing the final analysis, we'll, of course, be looking at, okay, within these countries, in a scale-up scenario, how things would look like, because you'll have, maybe it doesn't make sense to have certain clinics with a TrueNAT Mobile because they're only testing, say, 1 person a day. So it's not optimum usage. But maybe some clinics will have much more. And then when we'll do a sensitivity analysis, of course, we'll vary cost for staffing and other inputs, which, say in South Africa, might be more expensive. So while doing those sensitivity analyses, we'll sort of account for, a broader range of countries to sort of have a more generalizable answer. Yeah. Thank you.
Thanks for this very nice presentation. I had a question that actually follows on the question that was posed just now. That is about inefficiencies, because this is done in the setting of a trial. So in a trial, usually you sort of minimize inefficiencies, you optimize performance. And I think in real life, much will be driven by inefficiencies. And I can imagine that the both arms are not similar in the way they are susceptible to inefficiencies. So have you thought about that, and is that something, how should we deal with these data, even if we use them in modeling, to also account for those inefficiencies?
Yes, that's a very good question, and I'll try my best to answer. You might not be most satisfied with my answer. The way the trial is set up, and you're right, you might expect that in an intervention arm, things are being done in a much better manner. With the way the trial was set up, with the way people were enrolled, we tried keeping things as balanced as possible across both trials. Of course, the true cost of the intervention will increase further because there are a lot of hidden costs involved. Things in the real world would really not happen. We've tried to bridge that gap by accounting for implementation costs. So a lot of the studies would not look at cost of setup, cost of site finalization. When we were triangulating costs, when we had multiple estimates, we would always go for, okay, let's go for the more expensive thing, because maybe in the trial they procured the equipment at a cheaper price, to just run the trial. So wherever we could be more realistic, because there are other trials also done, the EXPEL study done as well is also looking at things in a similar manner. So wherever we've just been very conservative in that sense. We are not trying to say that, things are much cheaper doing things this way. In fact, the results show that, a per test cost with the mobile would be much higher. But let's see how we are seeing, the denominator. And then, of course, in our sensitivity analysis as well, being more realistic that things in the real world will actually cost much more. There'll be lesser efficiency. So that should be accounted to sort of give a more realistic real world picture. So yeah, that'll be our best effort. Thank you.
I was just wondering if you could spare a thought on that. This is obviously not an instrument which is just a uniplex. It doesn't just measure TB. There are obviously other cartridges one could use, which are not yet endorsed by WHO. But there would be efficiency gains if one would, for example, use it for viral load testing. And if you could kind of think about, aloud, on the spot, if you could take that into consideration as well. Thank you.
Yes, thank you so much. So yes, we, apart from gauging the TB infrastructure in the setting, we also looked at the HIV testing infrastructure as well, because to preempt something like this, that okay, we should look at multiplexing of tests, especially at the primary health level, especially in these settings. And especially when I said we can't just have a machine running one TB test a day. So yes, utilization could go higher if we are using other, looking at other disease areas as well, HIV and beyond. And that's why we got a sense of the HIV infrastructure as well. And that would be a part of some extended analysis that we'd like to perform as well. So, yeah.
Thank you, Akash. I think we move on to the next speaker, and we will save questions to the end. And I really encourage you to go to the symposium that you already mentioned that follows this session.
Our next speaker is Laura Olbrich from the Ludwig Maximilian University in Germany. And she will speak to us about clinical predictors of tuberculosis in children.
Thank you very much for giving us the stage today. I will be presenting some results of our pediatric study, RAPID-TB, which was EDCTP funded, and I'm doing so on behalf of my colleague Zoe Franklin-Smith from the University of Cape Town, who couldn't make it today, and our whole consortium, several of who are represented here today as well. So we've been talking quite a lot about TB and about the fact that there's a massive gap in TB notification rates across the globe, and this is especially a problem in children. We have around about 1 million pediatric TB cases every year with 250,000 deaths approximately. And if we look on the right-hand side of the slide, we see the global estimates on TB incidence by the WHO. Not the latest report, I didn't have time to copy-paste it, from the one from last year. And we see the estimated incidence stratified by age. And you can see in the black outline of the boxes the estimates, and in the colorful bars in the inside the actual reported numbers. And I hope the mouse works. Yes, it does. So if we look at the age strata below the age of 15, so children, we see we have the biggest gap here actually. So the biggest gap in case notification compared to those that we think actually have TB. And this is especially a problem in the children under the age of 5, where only roughly a third of children are actually reported. And this is mostly due to the fact that the diagnosis of TB remains very challenging overall, but especially in children. The standard diagnostic criteria, such as symptoms, are very unspecific, are not very sensitive, and the microbiological specimen types that we need to collect tend to be very cumbersome in their collection, such as induced sputum, but they are also very invasive. So we have a massive requirement on both the clinical and the laboratory side in terms of infrastructure to be able to make a diagnosis of pediatric TB. And this results in the fact that even in, so to speak, perfect clinical study settings, only 2 to 30% of children that are believed to have TB are actually confirmed by a reference standard method. So in RAPID-TB, we performed a prospective diagnostic accuracy study in 5 countries. You can see on the map in dark green where our clinical study centers were located, and in light green our consortium partners. And we recruited children under the age of 15 that were symptomatic and that had presumptive TB. Our TB workup was rather elaborate and definitely not necessarily the reality on the ground. We had 2 respiratory samples taken from each child at baseline. The first sample was processed using pellet using ultra and culture, and the second one was processed using culture only. We also collected a nasopharyngeal aspirate in children under the age of 5, which was analyzed using ultra. And last but not least, if the infrastructure allowed and was clinically indicated, we also collected extrapulmonary specimens because we also allowed for the inclusion of children with extrapulmonary TB. We had our study visits at baseline at month 1, month 3, and if children were on TB treatment and or were unwell at month 3, they were also seen at month 6. We followed the NIH consensus classifications of TB, which were confirmed TB. This was either culture and or expert, unconfirmed TB based on a number of different criteria, and unlikely TB. We recruited our first patients in January 2019 and had our last patient recruited in India in June 2021. This is an outline of our patient flow. We recruited more than 5,300 children across these 5 countries, ended up recruiting 975. And out of those, 24.5%, so 239, were actually microbiologically confirmed. 43.7% or 426 children were unconfirmed TB, and 31.8% or 310 children were categorized as unlikely TB. This is a bit of a busy table on some of the most important baseline cohort characteristics. I'm just highlighting a couple of points here. Our cohort was rather young, so roughly half of our children were under the age of 5. We had roughly 60% of children with HIV co-infection, 11% of children were presenting with severe acute malnutrition at baseline, and 34% were hospitalized when we recruited them. As mentioned, we have had quite a lot of microbiological workup, so we collected within the study more than 2,300 specimens actually. And this is why we had a very high microbiological confirmation rate of 36.2% in those children that were thought to have TB, so TB disease, so confirmed and unconfirmed TB disease. If we now look at how these children were actually detected, you can see that most of the children, 46%, tested positive both on culture and on ultra. 36% tested positive on ultra only, and 18% tested positive on culture only. The fact that so many children tested positive on ultra is actually especially interesting because we had many more cultures than we actually did ultras. And another point which is really striking is that a lot of these children only tested positive on trace. So across the whole study, we and across all of the children that were confirmed, 58 children were only confirmed by one single trace result. And I mean, for adults, we know that there's a lot of uncertainty around the trace call, that generally if the patients are okay, they're not HIV positive and it's not based from an extrapulmonary specimen, you're not supposed to understand it as confirmation of TB disease. In children, it's different. Any trace call in a symptomatic child is to be understood from a programmatic point of view as confirmation of disease. However, from a scientific point of view and diagnostic accuracy study point of view, it's a bit more complicated. So we looked a bit more into these children. So we kind of stratified by children that were only confirmed by trace compared to those confirmed otherwise and those with unlikely TB, and looked at a range of different clinical characteristics. And unfortunately, we don't have time to really dive into that. But one thing that I would like to highlight is this group. Those are children that were confirmed by trace at baseline, but they were not initiated on treatment because the clinicians on site thought they didn't believe it was TB and didn't start them on treatment. And out of those 14 children, the vast majority were well at end of study, so they were seen until month 6. They were well at end of study without being initiated on treatment. So we definitely need to do a bit more of workup of these cases. We also did multivariable analysis, and the only thing that showed up to be likely kind of associated with trace positivity was not even age, was not HIV positivity, but it was TST positivity. So children that were confirmed higher than trace were less likely to be TST positive. Or in other words, trace positivity was associated with TST positivity. So a lot of things to look into and to kind of go into a rabbit hole here. We also looked at routine lab findings and the use of routine biomarkers, for example, for blood count. And if we look at CRP in our study, we didn't see any difference between the three groups. But if we looked at the different ratios of the blood counts, so neutrophil, monocytes, and lymphocytes, we actually saw significant differences both between confirmed TB and unlikely TB, but also between confirmed TB and unconfirmed TB. And this has been described before, so we're not the first one to look into that, but this is definitely something interesting because full blood count tends to be available in a lot of the settings. We also try to look into clinical determinants of TB disease, as this talk also suggests. And this is an intersection plot, and I'm sorry, please bear with me. We will go through it. On the bottom, you can see different possible determinants of TB disease, and then the combination of which ones were present in the respective children. Then the intersection, so how many of those children that had either one of these determinants were positive. And then here you can see what these children ended up to be classified as. And without going into too much detail, there was not really anything that helped us very much with that. But it's a nice graph. We also did multivariable analysis, and we looked into confirmed pulmonary disease compared to unlikely TB disease, unlikely TB, sorry. And we could see that that only TSD positivity and a chest X-ray that is likely TB were associated with the confirmed TB status. Not very surprising. This was also similar in when we looked at TB disease, meaning confirmed TB and unconfirmed TB versus unlikely TB. And here it's specifically striking how high the adjusted odds ratio is for TSD positivity. And in the conclusions, I will get back to that. We didn't see any specific symptoms or number of symptoms that were associated with the outcome, and these patterns were very similar in different subgroups of interest as well. So children living with HIV, for example, or with severe acute malnutrition. Coming to the conclusions, we have the great fortune to have a very large geographically diverse cohort with a number of different subgroups also represented in high numbers. So this is a really nice study to do diagnostic accuracy studies. We have a very high microbiological detection rate in our study, and especially a very high number of children that were only confirmed by a single trace call. And what we have seen also, and I've not shown the details because of time, but we see that there's a considerable benefit of serial sampling, but also multiple testing. So not only taking to sputa, for example, but also testing it with both expert and culture. And this was especially the case for subgroups of interest. The clinical determinants of pulmonary TB disease were very similar to what has been described before, so sorry, nothing new to report here. And especially there's a big caveat because we applied the NIH consensus statements, which have, for example, TSD positivity and chest X-ray as part of their determinants to be classified into a certain category. So not very surprising that the regression analysis showed that there was an association. We also showed you the routine lab workup. CRP was not really helpful at all, in our study at least, but the different blood count ratio actually helped to differentiate between the different stages. And last but not least, we're using this data set together with other data sets in a new EDCTP study, DECIDE-TB, that started this year to look into the recently WHO-endorsed treatment decision algorithms and try to understand how these data or how these studies actually can contribute to optimizing what has been proposed. But similar to other diagnostic accuracy studies in pediatric TB, our recruitment was based on tertiary levels, mostly. So most of our centers were tertiary level university hospitals, 2 were more urban facilities, which obviously is an overrepresentation or results in an overrepresentation of true TB cases and thus biases the results, but also means that our study population is not really our target population of where the children actually present, because those are the ones in the communities presenting at primary healthcare facilities. So whatever comes out of our study definitely also needs to be looked at in more primary healthcare levels. This is obviously the work of a whole bunch of people, too many to name here. We also want to thank EDCTP, obviously, for making this possible, and all of the team and the children and caregivers. And if you're more interested in what we have done, we actually have 2 posters here at this forum. One is on lung functions, presented by Denise Banse from our Mozambican Center, and one on a novel finger prick assay. And that's it. Thank you very much for your attention, and I'm very happy to hear your questions.
Thanks, Laura. As the chair, I take the privilege to ask the first question, because my understanding was that you also looked at extrapulmonary TB, but you didn't present any results on that. And extrapulmonary, well, diagnosing TB in children is difficult, but diagnosing extrapulmonary TB poses an additional difficulty. Can you say anything about it, or you didn't look at it yet?
Oh. We have looked at it. So the microbiological results, the overall results also include the extrapulmonary cases. So what we've seen, for example, is that if we just look at the positivity rates across the different specimen types, the ones with the highest positivity rates are actually the so-called non-reference specimen types. So these are included, but when we look at clinical determinants, because they present so differently, like a meningitis case presents very different from a lymph node TB. We didn't include that when we looked into the clinical determinants. But this is, so we only excluded them from the clinical determinant bits. All of the rest, the blood counts and all of these things, they're included.
And what percentage was diagnosed with extrapulmonary TB?
I think 15% sole extrapulmonary TB, and we had quite some children with pulmonary and extrapulmonary TB as well.
Thank you for a wonderful study. I'm David Moore from South Africa. I'm just wondering about the highlight finding in your study and in many others of the importance of a TST positive result in assigning a correct categorization of a child with tuberculosis. Our finding on the ground in our public sector hospitals in South Africa is we've had stockouts of MAN2 and PPD, and we haven't been able to utilize TST to assist in the diagnosis of tuberculosis in children. And I'm wondering if you could just comment on our stockouts of PPD and maybe to make a recommendation to make it more widely available. Thank you.
Unfortunately, I'm not a politician, so I cannot really make a recommendation in that sense. So we were in the fortunate situation that we had supplies, so we didn't really have a lot of stock run out. I think there's a big difference between trying to assign a clinical case definition in a research setting and the programmatic approach to it, right? So I do think TST definitely has a massive value. But there's also a lot of problems with it as well. So yeah, I'm not sure that this helps you, but thank you.
There is time for more questions if there are. Very enthusiastic person.
So I'm very much puzzled, and I think many people will be, about those trace results for Ultra. And you also said these for hospitalized children. Were they hospitalized with children in a ward with a lot of TB? So could it be that even though we think that we don't pick up contamination, that we actually pick up contamination at the quote-unquote population level? Just throwing out a hypothesis.
No, I mean, we try to wrap our head around it quite a lot, and especially from so when we looked at our novel tests, we saw if we exclude those children only confirmed by trace, the diagnostic test accuracy estimates were very different. But it's also very difficult to, especially in a setting like that, just to say, okay, so you're trace positive, but we're not going to treat you, because everybody is very worried, especially about children testing positive. But my personal thinking is that I think we have not really understood it completely. And especially in a research setting, we kind of need to try to tease out a bit more what it means. I think contamination is definitely possible. We've also looked at stool testing, and we have seen a lot of false positives, so children where we're very sure that they didn't have TB that tested positive in stool, and we still cannot really explain that very well. So yeah, sure. We have so for stool we have done that. For the respiratory samples we have not done that yet.
I think first in the back.
Thank you, Laura. Nice presentation. Do you think those 14 trace positives could be subclinical TB? In adults, we see that about 10% of people with subclinical TB progress to active TB, so you could easily have missed that. We don't know much about subclinical TB in children, but certainly I can't really think of a reason why children should have less subclinical TB than adults.
That's a very good question as well. So first of all, we know from historical data that under the age of 5, around about 50% of children actually cure spontaneously. So that could be one potential explanation. Secondly, those children that were not initiated on treatment, I think only one of them was actually lost to follow-up. All of the other ones were seen for at least 3, sometimes even 6 months, and they were fine at the end of study. And all of these children that were not started on treatment and were not lost to follow-up were from the Indian Study Center, which is one of the best medical centers in the whole country. So they were very experienced clinicians, and they clinically said, we don't think this is TB, children were treated for other causes. So could be just a contamination, could be children actually self-healing, so to speak, or something else.
Thank you for your nice presentation.
So our next speaker is Bouke de Jong from the Institute of Tropical Medicine in Belgium, and she will talk about improving rapid detection of second-line drug resistance in Mycobacterium tuberculosis with expert MTBD, XDR, and MolBio second line.
Thank you very much. I give this presentation on behalf of Faridat Massou, who could not travel to this meeting. And it's a study that is part of the DIAMA consortium. And you see on the right Professor Dissou Afolabi, who's the coordinator of DIAMA. And also worth mentioning that 4 of the partners did their PhD during the DIAMA study. And Awa and Bassirou are here at the meeting. So in the DIAMA consortium, where Akash spoke about expert and TrueNut for rifampicin resistance, we were looking for rapid solutions for second-line drug resistance, culture-free, and also better monitoring options for the treatment of resistant TB. And here you see our last pre-pandemic consortium meeting in Bamako. So you see in purple the 9 countries that participated. And what I'll show you here is, you all know the expert cartridge, and now approved by WHO, second line. And then on the right, we also tested a prototype that was made specifically for this study of the TrueNut MolBio test. And then in purple, you see the different targets. So for, by and large, expert has more extensive targets. And the most important ones are included in the MolBio TrueNut test. But only for the MolBio was also the ATPE, which is the target of bedequalin, even if we know that most drug resistance is conferred through the efflux pump repressor. So on the right, you see the testing was done in all the countries. And for the MolBio, there was separate cartridge for the DNA extraction, and then first a chip to confirm TB, and then separate chips for the 3 different drugs. So we recruited all the consecutive RR patients in these countries and equal numbers of retreatment patients with rifampicin susceptible TB. And you see that the expert and the TrueNut were done on sputum. We also did the Dplex target NGS test on sputum, and then culture led to phenotypic DST as well as whole genome sequencing. And that was done at a minimum of 30x coverage with TB profiler variant calling. And the DST was done, as you see on the bottom, WHO recommended concentrations and conditions. And then the analysis, we used any resistance by pheno or whole genome sequence as the reference and excluded invalid or indeterminate results. And you'll show some examples of, see some examples of fluoroquinolone where we use the duplex in addition to resolve. So these are busy tables, but on the left you see the expert results, and on the right the MolBio results. And so the expert you see at the top as a reference, phenotypic and whole genome sequencing for isoniazid at about a 52% prevalence of based on the reference test. So the sensitivity for expert to detect isoniazid resistance was 87% and good specificity. And if we then at the bottom only compare to whole genome sequencing, so now we're comparing more apples with apples and mutations, the specificity, the sensitivity went up a little bit, and MolBio had a pretty good sensitivity, but more false positives for isoniazid. So ethionomide is reported by the expert XDR cartridge, but is the resistance to ethionomide is confirmed by more mechanisms, not only INHA. So not surprisingly, the sensitivity to pick up ethionomide resistance, which in this population was about 24% by the reference test, was quite low. And then there were also some mutations in INHA that were missed in the expert cartridge because the target is more limited than what is queried in whole genome sequencing. And then for fluoroquinolone resistance, this was fortunately low in the study country, so only 3%. So you see a rather low sensitivity with the reference test, but with a wide confidence interval. But then when we compare only to whole genome sequencing, sensitivity went up, specificity was excellent for all tests. And if we then look into the details of why was fluoroquinolone resistance missed in expert, at the top you see, so you see the OFLO2 result, which is low-level phenotypic resistance, OFLO8, moxifloxacin 1 was only tested for one sample. Then you see the duplex and then the whole genome sequence, including the proportion of the mutant population. So the two samples at the top had high-level phenotypic resistance. One had only 18% mutant, but duplex puzzlingly was wild type for both. This does raise the question, was there a sample switch, and was expert concordant with duplex or really false resistant? And then you see a series in green where you see that it was only resistant OFLO at 2, but sensitive at 8, and wild type in whole genome sequence. So this is the known imperfect correlation of pheno and geno for fluoroquinolone resistance, and this low resistance phenotypically without mutations tends to also be overcome by the use, especially of high-dose fluoroquinolones. And then at the bottom you see some more resistance missed in expert, but the limit of detection of expert for heteroresistance varies a little bit by mutation. It's for the rifampicin resistance, you typically need more than 50% mutant. And for the 94-glycine mutation, it should be picked up at 30%, but that may explain why it was missed. These are the other way around, and we did not see indications that these false resistance were unlikely, except for the bottom one where the duplex picked up the 94-glycine mutation. Then for the ATPE mutation in the TrueNut chip, not surprisingly, none of the isolates had a ATPE mutation in whole genome sequencing, and whereas there were 11 that were detected as resistant in the chip. And unfortunately for many new drugs, but especially bedaquiline, we're still far away from having a rapid molecular test because the clinical isolates with phenotypic resistance, it's all mediated now through RV0678, and that shows a wide variety of mutations, and not all mutations confer phenotypic resistance. So this was the wrong target to include in a test, but we did not see any mutants. And in conclusion, the expert XDR, so this one has in the meantime been validated, endorsed by WHO, and a prior data set that was not yet complete that you're seeing here contributed the largest of 3 data sets to that endorsement. Is working well for isoniazid, not so well for ethionomide, and on the other hand, ethionomide is rarely used now for the new regimens. And for the fluoroquinolones, it is accurate, but may miss heteroresistance, and like other molecular tests, will miss low-level phenotypic resistance. The MolBio TrueNut prototype does need more tweaking, and for bedaquiline, we don't really know yet how to move forward beyond whole genome sequencing and MIC testing. And then these are just some of the DIAMA analyses, so many more are ongoing, and that includes the comparison of diplex on sputum and whole genome sequence to look at culture bias and minority populations. And we're also analyzing culture-free methods to treatment monitoring, plus additional analyses on phylogeography and resistance also to new drugs. And then I thank you for your attention, but I also want to make some advertising for our course on drug-resistant TB for clinicians with hands-on experience treating TB patients. Please look at our website because the deadline for next year's course is December 15, and scholarships are available. Thank you.
Are there any questions? I see a hand over there. Adam?
Thanks, Björk, and congratulations to you and the whole DIAMA team. A question, did you look at the semi-quantitative load at all in the samples that you enrolled? Because I think you had a screening criteria of being positive and expert. Also, secondarily, did you see a lot of non-determinates in the testing on the MolBio assay? And then, do you have any hypotheses why the specificity on the INH chip on MolBio was below 90%? 3 questions.
And most of the questions I will not be able to address. So specificity, I think with MolBio, the DNA extract was more often giving indeterminate results, but I think that the next version has already supposedly is more sensitive for limit of detection of DNA in lower smear grading. With regards to the expert XDR, my understanding is it like the classic experts, the determination of the load was fairly similar. So if you're having an ultra trace, you're unlikely to get a good expert XDR result. So we're still struggling with the limit of if you have very little mycobacterial DNA, it's difficult to get a good test result for second-line mutations.
There's a question in the back.
Thanks very much. Just a quick question. Did you use the same sputum sample for the different diagnostic tests, or you took separate samples?
For that initial graph, the sputum that was decontaminated was used for culture and also for diplex, whereas separate sputum aliquots were used for expert XDR and MolBio, fresh sputum, not decontaminated.
I don't see any more hands. In that case, I would say we move on to the next speaker and then have a little bit time left for addressing all speakers in the end.
Our next speaker is Elizabeth Streicher from the Stellenbosch University in Cape Town. She will present to us about the interrogation of multi-drug resistant TB outbreak using whole genome sequencing.
Good afternoon, everyone. So for the last one, we have a little bit of a different direction. Let's delve into the genome of TB. And a little bit, not away, but yeah, a little bit away from the patients themselves. So I'm going to talk to you about something that was actually, a study that actually was done more than 10 years ago, started. And since technology has changed, we could actually now also learn a lot more as we delve deeper. So just to give a little bit of a background from where this outbreak of TB is from. So South Africa, we have 9 provinces, and Stellenbosch and Cape Town is located in the Western Cape Province, as indicated on that map. And then the Western Cape Province has 6 health districts, or 6 district municipalities. And the healthcare systems is also in these 6 health districts. And to your left in the green, bottom left there in the green is where Cape Town is, the main metropole. And the story that I want to tell you today is from the West Coast Health District. So just north of Cape Town, rural area, lots of agricultural activity going on. Beautiful area with beautiful flowers in September, if you want to come and have a look. So we were actually approached as a research group. The healthcare workers and the community workers in that area had a real found a real increase in TB incidence over at around 2009 to 2010, and also with some of our colleagues from UCT, they asked if there is really something going on, and specifically for TB, but more specifically for drug-resistant TB. So looking at the data over that time period, we actually saw that there was, in the 6 regions, the West Coast region did have a higher incidence of TB over that time period. And more concerning as that the drug-resistant cases was also really high in this region. So the healthcare workers was not just that they dreamt this up, it was really true. So this was also just after the big scare of XDR TB in KwaZulu-Natal and globally started to take off. So luckily in our biorepository that we had all drug-resistant cases in the regions stored away since 2008. So we could go and have a look if this was, what could potentially be the reason for this increase in drug-resistant TB in this region. So like I said, we had all these isolates stored away in this, in a bunch of -80 freezers that we could go back and have a look at them. So we started old school for now. We did genotyping just to see what the strains are, because we knew what was really in drug-resistant cases in Cape Town, and also in the other health districts in this region, what really is a strain circulating in the area, and what's the drug-resistant mutations of the most common drugs used at that time. but we didn't know what was going on actually in the West Coast region. So we started off with that through a master's study. And what we then fast forward a few years later, also report back to show that yes, in fact, it does look like there is an outbreak. It's a strain with specific mutations, with specific genotype. But fast forward a few years, when I got EDCTP fellowship, we were actually able to culture them again. This was in 2021. Culture them again and do DNA extractions and whole genome sequencing to be able to interrogate actually a little bit deeper. So from that time period that we had, like I said, we stored all these cultures from 2008, and at the time that it was in 2012. So we had isolates from this region from 611 patients, and we genotyped one sample per patient. And what we knew at the time was that the most common mutation, the most common strain that circulated in terms of drug-resistant TB in this region was the gray one. And then the second one is the yellow one in the whole province. But surprise, surprise, in the West Coast region, yes, the gray one is there still, but the blue one was the one that really stood out over this time period. And thinking back of this, if we could potentially have stored it maybe a little bit earlier samples, we could have maybe seen the peak of the outbreak as it went down. Because also we did test a few samples in 2013, but we excluded this because of the numbers that were still lower. But in combination, the 2013 samples, it was already much lower, the data. So it seems that it peaked around about 2008 to 2010. So this strain family in this region. If we look at it a little bit differently to where we found them, if you look at these regions where they were from, we saw that actually they are mostly in the middle, in the northern parts, the northern section, local municipalities that we found specifically this X family of strains that was drug-resistant TB. Additionally to what we found with them was also that they had mostly the same mutations that confers resistance to isoniazid, to rifampicin, to pyrazinamide, and to ethambutol. So very difficult to treat, and remember at that time we didn't really have any of the new drugs or haven't used really repurposed drugs at that time. So really difficult to treat, and then a few, not a lot, but a few of them also were considered pre-XDR at that time. So jump forward to 2021 when we started to culture and sequence these strains. So we selected all of them that was in this strain family that has in this strain family or has a CAT-G mutation, a specific one that does confer resistance to isoniazid, but it's not one of the classical mutations that you see always. And did a phylogeny of that and see correctly that they are really, it's one clone and not a lot of variation, but a lot of drug resistance. Yeah, so the whole genome sequencing analysis was also done with TB Profiler, and I think what we showed from all of that was that MDR TB was really in this region, and it was MDR plus because it was also resistant to pyrazinamide and ethambutol, was really transmitted. But as it gained additional mutations before it was transmitted, but there is potentially that there is could also now still be a little bit of pre-XDR that it could also start to transmit at that time period. No XDR-TB was found, and this was based on the new definition of XDR-TB. At the time, there was a few with the injectable drugs, but which is understandable because there was no new drugs yet. So those classes, so no acquisition of resistance yet, or internal resistance, which was a good thing. And then, so currently we are busy analyzing and using all the other pipelines and to see what we can have in terms of transmission hotspots and where did it occur and so forth. But what all of them really show is that there is this large group of strains that has this patients. There's 53 patients that has exactly the same, the bacterial genome is exactly the same. They haven't evolved anything more to acquire any additional resistance, but obviously have transmitted because of these patients all have the same, the exact same genome that of the bacteria that they're involved infected with. They're also mostly the same colors apply here, mostly from the two northern parts. And then from this group, there is some additional patients that had some additional evolution that went on and that transmitted to other patients. But all the mutations that happened at this point, at this point to your right, this is mostly second-line resistance and also compensatory mechanisms that to assist in fitness cost for the bacteria. So this is still ongoing, all the analysis and to look back, but I think, yes, it is an old study, and it's maybe not the same as what we see now with new diagnostics and rapid diagnostics. We also are starting to use really new regimens and stuff, but we can really learn a lot from old cases. And I mean, in history, we could have always learned a lot from what has happened in the past. So I'm not going to go into all of that again, of all the findings that we found, but I think next step is possibly what happened in this region, with these strains after 2012. We could also still learn a lot about that. And then what makes this strain so successful that even though it didn't gain any not a lot of additional drug resistance, it was able to transmit. And possibly what we will do in the future is also possibly compare this outbreak with others or other maybe groups of drug-resistant strains to see what is the makeup, the genetic makeup that makes them successful and in future studies. I think it does, in the end, will show that it is important to maybe make use of these genotypic techniques and those kind of things in surveillance study and specifically in neglected areas. This one, it's not even far away from a metro, and where we have seen a lot of studies, and you've heard about a lot of studies in Cape Town, for instance, but this is really a few 100 kilometers from there, and not a lot of studies has been done there at that time, I should say. But it also shows that maybe if we could use maybe whole genome sequencing as a diagnostic, we could prevent maybe acquisition of drug resistance, and specifically now when we have new drugs and new regimens that we can use, especially also highlighted in our previous talks with bedaquiline and all these new drugs. And then also this would limit possibly the transmission of drug-resistant strains that is circulated in areas if we could potentially diagnose them much quicker and be on the right regimen so much quicker if we use whole genome sequencing as diagnostics. So thank you very much for listening, and thank you to all our funders. Like I said, this was started many, many years ago and then continued on an EDCTP funded project that we are involved in. Then the students that actually worked on it and current postdoc that's still working on it. I want to thank just also the collaborators from the past and also the National Health Laboratory Service and specifically the late Marlene Bosman who helped us to store these samples, to collect them and to store them so that we can actually interrogate it so many years later. Thank you.
So it was a bit a different presentation, but the floor is open for questions.
Or maybe start a discussion with all the first ones too.
Yeah,
Thank you for an interesting presentation regarding that outbreak. I was just wondering if you've been able to start interrogating some of the clinical data and the outcomes of these patients to give us some insights as to their survival.
No, not us at all, not in our group, because we only had the isolates themselves and no clinical data that we had at the time. We did the healthcare workers and the clinicians in that region did interrogation of that at the time. I have no idea what any of the outcome, what the stats and data was suggested, and it was never published. I'm not exactly sure what happened, but that was in the clinical teams they did, and especially in the northern two regions, they combined all their data at that point, but I've got no idea what was the outcome of that, sorry.
In your presentation, you also mentioned, it's a bit of follow-up to this question, you also mentioned that there was an assessment of whether there were hotspots of transmission of this strain. Did anything come out of that?
Yeah, so we did narrow it down to basically 2 towns, but it is also the 2 bigger towns in those regions, so it is the hubs of that areas. And that was also what we see was that was also where most of the more resistance, the additional resistance to pre-XDR was where those strains were found. So it is also that they're closer to clinics, so more treatment available at that time.
Are there more questions for this presenter? I don't see any hands. And then are there questions or statements for discussion on the whole sessions? I think we still have 5 to 10 minutes.
I wanted to say something in relation to the last presentation. Normally when we do studies like that, they are sort of an academic exercise. But listening to this presentation, I find it a very, very important. How we can probably take it a little further and tie it to policy development, even in terms of treatment of patients. So I wanted to know from the presenter whether this is going to end as an academic exercise, because at the moment, one of our biggest problems in a lot of our countries is that this drug resistance, not only for tuberculosis, but many other infections. I also was reading something about how certain countries have gone beyond just looking at treatment of a patient, but also reducing to genotyping in terms of the population. So I wonder whether you're going to take it a little further and even look at the transmission patterns of tuberculosis. In what communities is this in relation to the study population that you're doing? And how you intend to probably take it a little further so that even the policymakers in these particular countries can look at even healthcare delivery a little bit different.
Yeah. I think very important question. And I'm sure there's some others that can also chip into this, since I'm not in the control programs as such. But for instance, transmission and to trace that and all of that, and if we do implement these high-tech and you know, like whole genome sequencing and all these data, and you end up with so much data, and to really rework that so that it makes sense. So in this case, yes, this happened 10, 12 years ago. So it won't have an impact specifically to analyze this data for this specific cohort of patients at this time. But what we're currently doing is using this data that we have with a lot of knowledge that we had in that time, maybe not treatment outcomes and all of that, but a lot of knowledge that we do have with it, dates of diagnosis, areas where they were treated and all of that, and where they lived and all of that, and combine that to actually develop and optimize pipelines to be able to do this in real time in the next settings. And I think, for this specific study, I think that's where it's important. So we learn to apply for the next one. And especially now with new drugs and new regimens and all the complications that there is with all these new possibilities of treatment, I think that becomes really very important. And also so that you don't end up with, cannot treat any patients with drug-resistant TB because all the drugs are being used.
Welcome.
Yes, I have a question for my co-presenters. I really enjoyed the presentations, but in this changing understanding of TB epidemiology and subclinical disease and children, I'm wondering if you have post-bacillary disease, you also don't need as many drugs and as long in duration. So yes, we are shortening therapy, but where do we go for maybe even shorter therapy for the trace positive with probably only a few bacilli? And I'm also interested in leprosy, and we can give only one dose of rifampicin and reduce incident leprosy by 50%. So then it becomes very different on your treatment threshold. But I'm wondering, when can we shorten the number of drugs and duration for TB for these very post-bacillary patients?
And I would even add that if you can shorten the treatment sufficiently, then your accuracy of your diagnosis becomes less important as well, isn't it? Does someone have an answer?
Yeah, I think that's a very good question. I think there are two comments. First of all, in pediatric TB, finally, we also have now the shortened treatment for 4 months for non-severe TB disease, in theory. Now, implementation is a big issue, right? Because you need chest X-ray, you need people that actually read it to be able to kind of judge it as non-severe TB disease. That's the first thing. And I think in order to be able to start with the evaluation of shortened treatment, we actually need to be able to categorize or give it like different degrees of severity. And at least for pediatric TB, that is very, very difficult because it's not about the bacterial load. So I hope in future, yes, but first I think we need some kind of grading system, scoring system or something like that.
Okay, I propose, oh, sorry.
Yeah, maybe I can comment a little bit on the developments in the TB drug world, because that's exactly one of the subjects which is very hot. It's about short regimens in any case. But the idea of the one size fits all is going to be abandoned a little bit. We are going more and more into a so-called stratified approach. And there are TB trials designed now where there's a lot of stratified medicine, so severe, mediate, non-severe, and maybe also subclinical, where you're talking about, although the diagnosis of that category might be difficult. And not only that, also in shortening of treatment, we are in the new consortia are now developing the so-called treatment duration randomizations, so where we do new regimens for 4 weeks, 6 weeks, 8 weeks, 10 weeks, 12 weeks, and we look at the results and see which duration is the best duration for that new regimen. So there are quite some developments in those directions. The combination of stratified and treatment duration randomization, I think that will give some answers in your direction.
To be presented in the next EDCTP forum? Okay, then with that very positive note, actually, I would like to close this session. Thank you to the speakers. Thank you to my co-chair. Thank you to the audience here, but also to the audience online, and enjoy your break. They didn't make it difficult for us. We didn't have to stop anyone. It's always the worst, if you need to, if everybody starts to sit like this, they go over 20 minutes and then